I think we've had a really good discussion around TALAPRO-2. Any final comments or pearls of wisdom you want to leave our audience with?
I think I do like to discuss testing with you. You have spoken. I have seen you talking about testing, how important it is to test our patients. And I think I'd like to just mention briefly that every single patient with metastatic prostate cancer, all guidelines, I think, across the world support genomic testing or genetic testing. Germline testing, tumor somatic gene testing should be done in these patients, even though we do not have a targeted therapy available for these patients in the hormone-sensitive setting. Based on our experience with PROFOUND trial, we know that by the time these patients develop mCRPC, those tissues become old. They lose their quantity or quality. So I think it's so important to test every single patient who present to our clinic as long as they do not have genomic testing results available. Germline testing is so important because many of these patients have these mutations with implications on their family members, their children, their siblings. Beyond that, I think I still see role of mutation profiling even in metastatic hormone-sensitive prostate cancer setting, even though there are multiple trials which are going to be reading out in next 1 or 2 years, including the TALAPRO-3 trial, Amplitude trial, Capitello trial. All of those trials are really recruiting patients based on underlying mutations. But taking a step back, if I see P53 mutation, P10 loss, RB loss, I know these patients need to be monitored closely. These patients may not be relied upon. I would take a step back. Their disease may not be relied upon to manifest progression as a PSA progression. For example, these patients can have radiographic progression without a proportionate increase in the PSA, especially with RB loss patients. On the other side, if I see a patient who do not have any of these mutations and who have SPOP mutation, I feel so comfortable not seeing those patients for 3 months. Especially, I don't feel compelled to have them come to the clinic. When I order scans, I tend to order scans every 3 months in these patients who have these tumors, have lost tumor suppressor genes. So P53, P10, RB loss patients, I think they are more likely to have imaging progression within a shorter time frame compared to other patients. So going beyond the treatment, I think these mutation profiling has so much impact on how I monitor these patients in the real world, how often I do scans, how I counsel them about prognostication. So all of this.
I think you raise a really, really important set of points about the role of the testing. It's only going to increase. As you mentioned, there are metastatic hormone-sensitive trials that are going to be biomarker selected. So we'll have more and more reason for the testing, and really nice to be able to start personalizing our treatment instead of treating all prostate cancer patients the same.